together. So we'll be looking at surgical site infections for our topic today. And our first speaker is Perry. He's one of our research fellows here from Bochum, Germany, and he's going to be looking at the various interventions that we can do and sort of systematic review looking at all those options that we have available to us. So thank you, Perry.
Thank you for the introduction. Let me introduce myself for 1 second. Just Perry Godolias. I'm a trauma surgeon, orthopedic surgeon from Germany, the beautiful city of Bochum. And I'm here to do 1 year of research at SSF. And I was assigned to talk a little bit about perioperative antibiotics. So before I get to the systematic review that I wanted to talk about, me coming from Germany, it's of course kind of a new thing to see how the guidelines are created in the US compared to Germany. So I wanted to show the audience that there's, first of all, 2 institutions which play a big role in the US. That's the American Society of Health System Pharmacists, which give out guidelines for the practitioners. They report to the FDA and the CDC, which are governmental agencies, and they set a minimum standards for the use of drugs in the medical practice. So when you look through their guidelines, and I wasn't even able to find out when they have been published somehow, but you will find a chapter called Spinal Procedures with and without instrumentation. And they cite on some studies which are basically from the 90s, and one study which I think was a systematic review from 2009, and they come to the conclusion that giving these rates of surgical site infections, that cefazolin is a suitable agent, basically in its spectrum, and that a broader coverage can be carried out by the practitioner if he may think that there are gram-negative bacteria playing a huge role in this patient. They give out this therapeutic guideline stating with and without instrumentation, not making a big difference there, and saying that, as I said, cefazolin and clindamycin and vancomycin should be kept as extra agents for more severe SSIs. They give out this little table, and the whole spine surgery department gets this little line down here in this table, which just states what I just said, and they give it a grade of evidence of A. Then there is the North American Spine Society, which had been founded a little bit later, and they give out guidelines as well. So they come to 2 consensus statements when it comes to perioperative antibiotics, which are more or less the same as the other institution as well, and saying as well that cefazolin is that what we use, and a single shot preoperative is basically enough, and only if the practitioner has an idea because of some samples or something that there are other bacteria playing a role. But then, of course, we're not talking about prophylactic anymore, because then we already have a sample. We can choose other antibiotics for that. So just for this little excursus now to the systematic review that I chose. This is a recent one published in the Journal of Neuroscience in 2018. They included actually all the papers they found produced in the last 20 years on surgical site infections, just excluded the pediatric patients and papers not written in English. And those reporting on pre-existing SSIs, and they included in the end 11 randomized controlled trials, 51 case controlled studies, and 7 case series. They come to the conclusion that the administration of a single dose preoperative reduces the SSIs, as we all know, and as we all do it already since a long time. They say that the multi-dose does not give a better result compared to a single dose in the lumbar instrumentation. That's basically the only statement they make on instrumented spinal fusions, and that extending of the antibiotic interval does not have an advantage neither. This is all grade B evidence after Wright et al. So it's strong, but not as strong as we would wish it would be. So to outline the two findings of them is basically in the discussion that there's only one level 1 study in the last 20 years, which showed, which was about the antibiotic prophylaxis in instrumented lumbar fusions, and which comes to these conclusions that all the other institutions come to as well, and that these findings match the guidelines that we already have right now. As a limitation for this systematic review, we could say that they were not mentioning in the methodology part that they were sticking to the PRISMA guidelines, but since they have been published in the Journal of Clinical Neuroscience, I think they have to stick to the PRISMA to even do the submission. So I don't think that this is a real limitation on that.
Thank you, Perry, for the concise review. Again, it's a pretty robust systematic review. Many of the findings in there were not especially conclusive, so thank you for focusing it in on the perioperative antibiotics. I think these are questions that we look at. We kind of redose antibiotics just because it's what we've always done. Really no evidence to support that as opposed to one perioperative dose. I would think that in our longer instrumented fusions where we're spending 8-10 hours in the operating room, it's probably a good idea. But the outcomes are just, the incidences of infections are so low, it just takes such big numbers and things that we need to look at more closely. Any other thoughts?
I have a question. So you're a young trauma surgeon. So in trauma surgery, more recently, there has been the thought that we should use much higher doses of medications, and that would include antibiotics also, I presume, to kind of get a meaningful serum level. So the shock situation, the volume substitution theory obviously would apply. Did the authors in these studies, the systematic review or the primary source evidence, actually address the issue of magnitude of surgery, not just the duration like what Dr. Abdul-Jabbar said?
No, they did not address the magnitude of surgery, but the duration actually. And but there were no guidelines pointed out when it comes to the duration. From my own practice, I know that in bigger revision prosthetic surgeries, we do another single shot antibiotic after 2 hours. In trauma cases, usually we try to keep it for the first in the first surgery after trauma. We're trying to keep the surgery less than 2 hours because of the second hit.
May I ask Dr. Lieberman? Izzy, are you live?
I am live. I am here.
So should we, when we do larger, big cases, like Amir did a very large tumor resection yesterday, should we kind of high dose our patients intentionally to kind of get meaningful serum levels in addition to redosing them later?
I don't know the answer to that. I have not been overdosing or high dosing them, but I must admit that I encourage my anesthesiologists, instead of waiting the full 4 hours, maybe redosing at 3 hours. And we're very, very critical about managing fluid volume, minimizing blood loss, not overloading the patients, and not diluting the patients. So we're looking at it from another perspective, but I don't know the answer if we should be using higher doses.
One thing that I've always wondered is, and maybe we'll ask Dr. Ziegler for that, as we looked at discectomies, has anybody actually ever found, and this is very pertinent to disc arthroplasty, so Scott and you can maybe answer that because Rick is gone. Has anybody actually ever shown that there's serum levels of antibiotics that are actually discernible in tissue samples of discs intraoperatively?
Jens, not that I know of, and there's not even any evidence to suggest that these patients need to be prophylaxed down the line. We do it empirically, and we usually tell them if the dentist asks, then do it, but we don't have any data, and these are non-synovial joints, so we have no idea, as you're alluding to, whether oral or intravenous doses even get into a healed disc space after an arthroplasty. So it's unknown science.
One of the things, Jens, that I wanted to add on to what you're talking about when we're going with higher doses, and this is one of the paradoxical things that we saw with the vancomycin in the incisions. all of a sudden we started getting papers coming out showing that vancomycin inhibited the osteo induction and diffusion rates. So we've got to be careful. Everything that we think may address one issue may result in other problems that we don't want to run into in some of our bigger cases.
Thank you for bringing that up. I think we will be touching on that a little bit later, so let's put that on the back burner. But going on to the next paper, wanted to introduce Ravi Nunna, one of our other great fellows. He's going to be talking about posterior approaches to the cervical spine. So go ahead, Ravi.
Thanks, Dr. Abdul-Jabbar. Good morning, everyone. I'm going to be discussing a paper by Sebastian et al. Titled Risk Factors for SSI After Posterior Cervical Spine Surgery, based on the NSQIP database. The study design for this project was a retrospective cohort study of prospectively collected data based on the ACS NSQIP database. The objective was to examine incidence, timing, and risk factors for SSI following posterior cervical surgery. The authors intended for this project to evaluate specifically posterior cervical surgery, just because previous literature had noted a significant difference when comparing anterior versus posterior cervical surgery. So they were hoping that this study would guide clinical decision-making. In addition, there were few large studies that examined specifically posterior cervical surgery. So the authors hypothesized that there were unidentified unique risk factors in this group that were predisposing them to higher rates of SSI. Just some background info on the NSQIP database. Very unique wording, but it's retrospective. However, it's prospectively collected, and it's validated, and it is routinely audited by a number of groups. The data is collected by trained abstractors that review clinical documentation such as progress notes, results, inpatient diagnosis codes, essentially. In this study, they looked at 30-day postoperative mortality, complications, and unplanned readmissions, all of which are available in the NSQIP database, in addition to patient demographics, comorbidities, and perioperative risk factors. This is a national database, and it has over 400 participating institutions. Patients were identified using CPT codes between the years of 2005 and 2012, and patients were stratified into 3 different groups. Posterior cervical decompression without fusion with the listed CPT codes, cervical laminoplasty, again with those CPT codes, and then finally posterior cervical fusion. Notably, the SSI definitions were, again, they looked at timing out to 30 days, which is all that NSQIP allows. Now, the NSQIP has a data file in a dictionary that basically states the definitions for these, and the authors went ahead and included this in this project. And superficial SSI is determined as diagnoses made by the surgeon and must have some signs or symptoms of infection, such as pain, induration, erythema, or drainage. Stitch abscesses and burn wounds are excluded. Deep SSI are described as infections involving the deep tissue that extends to the fascia and the muscle layers. Infections that involve both deep and superficial layers were considered deep SSI. One interesting note was through previous auditing investigations, there was found to be a gradual improvement in the rates of basically agreement between the auditors. The disagreement rate fell from 4.7% to 2% between 2005 and 2008 for superficial SSI, and from 2.7% to 1.3% for deep SSI. Overall, this study found 5,441 patients that satisfied their inclusion criteria. About 70% of these patients were actually surprisingly standalone posterior cervical decompression procedures. 23 were fusion procedures, 8% were laminoplasty, and the overall rate, as pictured in this pie chart, was 2.94% for SSI, whether superficial or deep. So SSI occurred within 30 days in 160 patients, of which 80 patients were identified as having superficial SSI. So about 50% were superficial, 50% were deep SSI. Notably, no significant difference was found in SSI rate between decompression, fusion, and the laminoplasty groups. However, there was a trend towards lower SSI in the laminoplasty group, 1.7% versus between 3 and 4% for the decompression and the fusion groups. The mean time for diagnosis for both deep and superficial SSI was a little over 2 weeks. So obviously something that the authors discussed was important in terms of evaluating and monitoring the patients postoperatively, even after the 2-week follow-up visit, that actually most patients are diagnosed with infection after 14 days. And then of the 219 patients in this entire cohort of 5,400 patients that had an unplanned readmission within 30 days, almost 40% of them had a diagnosis of postoperative SSI. So clearly postoperative SSI is a massive driver of unplanned readmission, and that's probably the foremost quality benchmark that we have during a clinical review, contemporarily. This is a table of the SSI results and patient demographics. Mean age was about 60 years. Females are about 40%. There was good representation in terms of ethnicity, and here's just some of the other listed factors that the NSQIP database allows for, such as BMI, smoking status, COPD, CHF, hypertension, diabetes, chronic steroid use. In addition to several laboratory markers such as renal laboratory markers, nutrition laboratory markers such as albumin, and then blood counts such as hematocrit, platelets, and then also the ASA class. This is a chart that the authors listed. This is based on the univariate analysis. The authors did both a univariate and a multivariate logistic regression analysis. Based on the univariate analysis, risk factors for SSI that were identified were BMI greater than 35, chronic steroid use, albumin less than 3, hematocrit less than 33, platelets less than 100, and an ASA class greater than or equal to 3. The authors noted here that while BMI and chronic steroid use, while in the acute period, are likely not modifiable risk factors, in the long term, over a year, this may be modifiable, and albumin and hematocrit and platelet status might actually be modifiable more in the acute period. Here, I thought was really the meat of the project. This is the multivariate logistic regression analysis, identifying independent predictors for SSI. The independent predictors were actually, notably, it was age between 50 and 59, and then age greater than 70. So for whatever reason, between the ages of 60 and 69, that was not an independent risk factor for infection. Again, BMI greater than 35. Chronic steroid use, albumin less than 3, hematocrit less than 33, and platelets less than 100. None of these played out in the multivariate analysis. And then operative time greater than 197 minutes was an independent risk factor for SSI. So clearly here, there was only a couple of these factors that actually played out in the multivariate analysis. The limitations that were stated in their project were fairly slim, but the stated limitations were coding errors by the data extractors, inter-practice variability in regards to perioperative care by the different institutions. The data was limited to 30-day outcomes, but the authors noted that while this is likely sufficient for postoperative SSI, going out to a little bit longer may actually capture more patients. And then finally, and I think most importantly, specific variables that are interest to spine surgeons, such as number of levels, intraoperative blood loss, the use of local antibiotic therapy, and indications. None of these are captured by the NSQIP database, and these can all significantly alter the rates of postoperative SSI. So overall, I think it's a great project, especially due to the size. And then, as Dr. Chapman had mentioned to me prior, this allowed several organizations to set benchmarks for rates of infection. So I think the rate of infection in this study was about 3%, 2.94% for posterior cervical surgery. So definitely useful to know that.
Well, thank you, Ravi. That was a very good review. I think you brought up this point that the NSQIP data is very limited. It gives us a much wider net. And I think one of the things we get very focused on here at a fellowship center where we do a lot of complex spine that the community is really not representative of us as a kind of center of excellence, if you want to call it that. And I'd love to hear some other people's opinions where, the amount of posterior decompressions that are done here is fairly small, where it's far and away the vast majority of the cases that were done, and the rate of infection of over 3%, approaching 3% for a posterior decompression seems unusually high. Again, because there's no granularity in the data, I think we're limited in what we can draw from that. But I appreciate you bringing up that point, and would like to hear some other people's experiences with how much posterior decompression is really being done out in the community. Again, this is an older paper, but still kind of opens my eyes to what's happening out there.
Let me ask Dr. Schonert, who co-founded the only at the time spine registry that was statewide scope before it became politicized. Dr. Schonert, that data cleansing and data auditing, that's a really big deal. Can you just, in a very short period, just elucidate some of the problems that go into data cleansing and auditing?
Yeah, it's a nightmare. When you look at human abstraction, you have a minimum of 40% data errors. They're either improperly coded or they're incomplete data. So when you look at the NSQIP, it doesn't pass the smell test. There are so many aspects of what they do show as benchmarking, what they do show as a unified attempt around a common purpose. But they have a fundamental flaw in human abstraction, and you will not be able to get away from that. So you cast a wide net, but there's a very large hole in your net, and a lot of data goes out of it.
Yeah, can you just briefly talk about NSQIP in terms of who's actually contributing? Dr. Schoenfeld just raised that very important question. So just give us a quick survey of who actually contributes and how is that representative of the overall surgical population. Neil?
As far as NSQIP from the College of Surgeons, yeah. So they participate as hospital entities. The charge is anywhere from, I think, around 15,000 to 60,000, depending upon the size. And most of them are not the community centers that are represented in scope.
So yeah, so this is a voluntary or an involuntary participation?
That I don't know, Jens.
Yeah, it's a voluntary participation, so you have to basically be selected for it. So there's a significant, Dr. Schoenfeld supported that right now. It's a voluntary participation. So there's a significant possibility for selection bias. That's the point. And again, the actual illness impact of patients is very rudimentarily, but maybe effectively reflected with the ASA score. So we don't have actual more sophisticated illness impact factors. Same as for the previous paper, where we really don't know all of the variables that go into place, but it's important. It sets a standard and a benchmark, and again, this 2.9% has become kind of a factum as our American board has selected this article. It's one of its sentinel articles. Should we move on?
All right, thank you guys. Next up is Dr. Paul McBride, another one of our great fellows here for only 6 months. We're very sorry to have you leaving soon. You've done a wonderful job, so thank you for all your work.
Thank you.
So next study is going to be looking at staph infections in orthopedic implants.
Thank you, Dr. Amir Abdul-Jabbar. My name is Paul McBride. I'll be switching gears a little bit. We're going to be talking more about the basic science aspect of this surgical problem. This paper is titled Evidence of Staphylococcus aureus Deformation, Proliferation, and Migration Canuliculi of Live Cortical Bone in Murine Models of Osteomyelitis. Before I get started, I just want to say that this paper is one of the authors, Dr. Stephen Cates, who gave a great talk at the Washington State Orthopedic Association on May 27th. And this has been uploaded to YouTube on our SSF channel. So if you want more information about this paper and about many other of his recent papers, I invite you to please listen to the man that did the research himself. So just a quick background, Staph aureus accounts for the majority of osteomyelitis cases. A chronic staph infection is considered to be an incurable disease for various reasons. They can form biofilm that's pretty well known now on necrotic tissue and on the implants. The staph can actually live intracellularly inside of our osteoblasts and osteocytes, which is also well known, as well as form what's called Staphylococcus abscess communities, or SACs, which are little pockets of staph that sort of wall themselves off with a pseudocapsule inside the trabecular bone in the medullary region of the bone, and prevent themselves from getting attacked by our immune cells and antibiotics. This has been pretty well described using scanning electron microscopy, and this has been shown in many animal models. But transmission electron microscopy hasn't been used to describe staph's behavior, and that's what this paper sort of set out to do. On the right, you can see, this is from a prior Stephen Cates paper. You can see the biofilm formation starting at 7 days and progressing on, maturing 14 and 28 days. And this should be a very scary thing to look at as surgeons, because you can see by 7 and 14 days, you have a pretty mature biofilm forming already on the implant. And what they found was that the biofilm actually peaked at around 40% of the surface area of the implant. And they think that this plateau has to do with the immune response of the host, sort of damping it down and leveling it out at about a 40% coverage, which is what they found consistently. The other interesting thing they noted from this earlier paper is that as the biofilm develops and matures at 7 and 14 days, as you start to get out to 28 days, they started seeing little empty pockets in the biofilm where the bacteria had actually sort of detached themselves and moved along to spread throughout the implant. So you see this kind of honeycombing pattern on the 28-day area. And they found this gene AGR was responsible for allowing them to do this and spread along the implant. So the methods they used in this paper was a mouse transtibial pin implant model, and they've used this model in several other of their papers, which is a very nice model where they soak a small pin like the size of a 28 gauge needle in a bacterial broth and then surgically implant it in the tibia of a rat. And you can see how you get nice, predictable, progressive osteolytic osteomyelitis response in the rat. They also did a femoral osteotomy model where basically they cut the femur and inserted a small fibrin matrix soaked in staph as well. And in those rats, they had drink BRDU drinking water and then looked at those cells under electron microscopy that were then labeled with gold so they could see the uptake of the cells. And I'll explain that a little bit later. They then went on, because they found such an exciting result from these models, they went on to look at this staph's behavior in an in vitro model in order to observe this behavior in a little bit more artificial controlled setting. So the main result of the paper was that they found that Staph aureus was observed to live and propagate in the canaliculi of the live cortical bone. So in this top right picture, you can see this staph sort of attaching itself to this opening of this canaliculi. And remember, canaliculi lead to the lacuna where the osteocytes live in the cortical bone. And it's sort of attaching itself at the opening here. And what they found was that the staph would actually divide asymmetrically and sort of march down the canaliculi with each subsequent daughter cell. And this had never been seen before with staph. This is a completely new finding. As we know, staph is typically a coccyx, so a round shape. But as you can see in this bottom right figure, you can see it's taken on a bacillus shape. And it's gotten to be a very small, up to 0.2 microns, which is 20% of its normal size, in order to propagate down. And so all these characteristics of staph were previously unknown, that it can change shape, that it can asymmetrically divide in order to propagate itself, because it doesn't have a tail or any motile apparatus. So they were able to see it sort of moving along, proliferating at the leading edge. These are various slides that show the same thing. You can see the top left figure. You can see this medullary region of the bone where you have a neutrophil here. And you can see the canaliculi leading right into that. And this really demonstrates, this picture is great because it shows how this immune cell is not able to enter the canaliculi just based on size. And so the staph are really able to hide from our cellular immune response very well and nicely in these areas. And these slides were all taken at 14 days. So this should be very scary that, just 14 days, this is how deeply infiltrated the staph is. In this middle figure E, you can see that the distribution of the staph in the cannuliculi is not always even. So you can see this one on the left is packed with staph, and this one on the right is not really as packed. So they didn't know exactly why this was happening, but it wasn't very evenly distributed. This was another paper that was subsequently done that just proves that this actually does happen in human, not the mice model. This is a diabetic foot on the left. After removing the toe, they put it under the same process of transmission electron microscopy and showed that they do see this in humans as well. So this isn't just a phenomenon in mice. This was the next sort of experiment that they did. And basically, I'll sort of, because of my ignorance and time constraints, I won't go into the methods, but basically they labeled the drinking water with BRDU and then tagged it with gold and looked at it under the electron microscopy. And this is important because it basically proves that the leading cells are newly divided after they drank the water. So basically it shows that this is actually how the cells propagate, is by division. And the other thing that also shows is that potentially antibiotics, oral antibiotics or IV antibiotics can reach these cells that are in the bone. But they don't think that this is going to be effective because not only does it not get there in very high concentrations, but these cells are so slowly dividing, they're almost in a dormant state that the antibiotics won't be able to be effective because they require cells to be rapidly dividing in order to be effective. This bottom panel of the figure is a study where they basically took an artificial membrane that had 0.4 micron holes in it and put staph on one side and then just looked at the other side. Labeled with GFP. And basically you can see on the bottom L to P, these are 15-minute intervals, and you can see how quickly the staph is sort of moving through this membrane. And again, this is at 0.4 microns, and staph are supposed to be at least 1 to 2 microns. They also, subsequently to this, in a paper, identified the gene that was responsible for doing this, penicillin binding protein 4. And so that was in the knockout versions of these staph, they were not able to do this. So that was another important finding that they later found. So what does this all mean, and how does it affect us clinically? We know that staph is a well-studied organism that's a non-motile cocci, has planktonic growth, it has biofilm growth, and it also has intracellular growth. But chronic osteomyelitis remains difficult to treat despite all of our efforts of antibiotics and surgical debridement. And this is another method that was found that may be an explanation for why this is the case. The cannuliculi are too small for our immune cells to infiltrate, and antibiotics may reach there but are ineffective. Do we need to redefine what an early infection means? A lot of surgeons have a 2-week or 3-week benchmark in their head that says, okay, I'm not going to take the implants out. I'm just going to wash this out. It's too early for a biofilm to develop. It's too early for the bone to be infiltrated. I don't need to do an aggressive surgical debridement of the bone. I'll just wash things out. But these cells in the cannuliculi that are there before 14 days, you can't scrape these off with a cob or a curette. These are within the cortex of the bone itself. And so it makes us sort of reconsider what an early infection is and how we treat it. The other important finding of this is that it provides potential new targets for therapies. I mentioned a few genes that are involved that they have subsequently identified as being important for staph to be able to do these things. Penicillin binding protein 4, the SAS-C gene, which allows the cell to divide forward in progressively smaller stages, and this AGR gene, which is responsible for the cell sort of adhesing to the cortex. So these could be potential therapies down the future for somebody with staph. And then also possibly coming are new diagnostic tools to more sensitive than an ESR or CRP, for instance, to test for chronic infection. And I'll just highlight some of the clinical pearls that Dr. Cates had mentioned in his talk. That he could take from his research. And again, redefining an early infection with a low threshold for an implant removal. When you're doing a washout case, make sure to take multiple cultures, especially if there has been treatment with antibiotics beforehand. Definitely consider replacing the implants if there is a staph infection. Again, with spine, it can be tedious to replace an entire construct and go take them back to replace the hardware at a later time, but it should definitely be considered. A thorough bony debridement and all devitalized tissue should be excised as well. So thank you.
Thank you very much. Very interesting paper, very scary. I think to know actually the inner workings of how these infections occur and maybe hold us to a higher standard of what we're doing in our intraoperative debridements. I think one interesting thing in spine, we've kind of been shielded from the general orthopedic principles that we're all taught with, you know, no implants in the face of infection has not been kind of generally taught to be as important in spine. And I think this makes us question that. Jens, what do you feel about infections? I know sometimes we have no choice in a very severely collapsed osteodiscitis, for instance, to put some sort of support. We will talk a little bit later about approaches for dealing with that, but what is your kind of threshold for deciding when to exchange hardware, when to leave it?
This is a great question. Thank you. And thank you, Paul, for an excellent summary of a very complex body of work. My exposure to Dr. Cates' work has changed how I practice. So I have no doubt that stability is important in the management of unstable musculoskeletal structures. It just decreases the amount of unwanted side effects of inflammation and helps tissues heal. But at the same time, if you have staph specifically, we do have a problem. So I think that a staged approach like what both of you have insinuated is a very smart approach. You put in a stable but maybe undersized hardware, and as the initial damage control fixation, you follow the principle of debridement down to vital tissues. And put whatever agents you want to put in there for antibiotic management. And then at a later date, when the patient has overcome seemingly the infection, do the definitive reconstruction with new hardware. So that's been my change.
I think there's also an important difference between putting hardware in an already infected patient that's had antibiotics and a new surgical site infection at the time of new hardware implantation. I think there's a different biology going on there.
Yeah, so we should probably move.
Yeah, thank you. Yeah, let's keep moving. Next, we have Dr. Rick Price. Thank you, Paul. And going to be doing our Vancomycin paper, I believe. So go ahead, Rick, whenever you're ready.
Okay. Hi, I'm Rick Price. I'm initially from WashU, where I did my neurosurgery residency. I'm finishing up here at Swedish this month. So yeah, my paper is out of Emory, is published in the Spine Journal in 2018, and it's the impact of prophylactic intraoperative vancomycin powder on microbial profile, antibiotic regimen, length of stay, and reoperation rate in elective spine surgery. And over the last decade or so, there's been a lot of push to put intraoperative vancomycin powder in the surgical field, particularly of instrumented fusions. And what they were interested in was taking a look at the infections after, the surgical site infections after the vancomycin powder, and they wanted to compare the microbial profile for these type of infections versus patients that did not have any vancomycin. And they went further and they wanted to examine the effects of the vancomycin powder on the extent of required treatment if the patient comes back with a surgical site infection. And as we know, postoperative spine infections are rather devastating. It has an incidence of anywhere from 0.7 to 12%, depending on which paper you read. And they're expensive. They cost about $34,000 to treat, and requires extensive IV antibiotics and potentially surgery for washout. And then, as I was saying, that as prophylactic antibiotic intraoperative vancomycin powder has gained traction, it's been shown to decrease the rate of surgical site infection. But with this vancomycin powder being put in primarily for gram-positive coverage, there's a growing concern that the microbial profile in these patients that come back with a surgical site infection may favor more resistant or uncommon organisms, such as polymicrobial infection or gram-negative types of bacteria. So they did a retrospective review at their single institution at Emory for patients that underwent a posterior thoracic and or lumbar spine surgery between 2010 and 2017. And they defined a surgical site infection that being clinically significant included in their study if they required a return to the OR for irrigation and debridement. And their standard dosing of intraoperative vancomycin was 1 gram of powder that was placed in the wound bed immediately before fascial closure. Interestingly, at my institution where I trained at WashU, we gave the amount of vancomycin based on the size of the incision, where smaller incisions got maybe 0.5 gram, or if we did a T3 of the pelvis, typically would get about 3 grams. So it seems like they have a pretty standardized protocol at Emory. And then these patients were divided into 2 groups: patients that did get the vancomycin powder were considered "quote unquote" treated, or the patients that did not receive any intraoperative vancomycin powder. These are the untreated groups. So looking first at the patient characteristics, first of all, they screened 5,909 patients screened. They had 115 infections that were included in the study that required IND. This is about a 2% infection rate, which is within typically what you'd expect for spine surgery. So they looked at the patient characteristics between vancomycin treated group and then the untreated group, and several statistically significant factors came out, including mean BMI was barely significant, with vancomycin treated being a little higher, which unclear what the significance of that is. I want to take your attention down to arthrodesis and prior spine surgery. Interestingly, the arthrodesis group with vancomycin treated is 78.6%, versus the untreated was 38.4%. And then also prior spine surgery was significant towards the untreated group, with 46.6% being treated and 26.2%. And I think the arthrodesis portion is, in most institutions, all patients that have an instrumented infusion get vancomycin, whereas patients that have uninstrumented may not get any intraoperative antibiotics at all. So this may be skewed just by what types of patients actually get the vancomycin. So they did a multivariate analysis on these patients of all the patients grouped together, all 115 patients with a surgical site infection. And then the 2 factors that were, again, statistically significant was fusion, which is actually a little protective, 0.38 chances of having a surgical site infection. Again, I think those are the patients that had a lot of intraoperative vancomycin, but then also prior spine surgery, odds ratio of about 3, which makes sense that as patients have more and more spine surgery, I think the rate of infection increases. So table 3, they looked at the most common culture results among all patients with surgical site infections is both the treated and untreated group. MSSA is still the most prevalent, accounting for about 36% of infections, with polymicrobial accounting for about 15%. And then no growth, about 24% of their patients had no growth in their cultures after irrigation and debridement. And this table here breaks down, and this is really the meat of the paper. It breaks down the type of infections based off the organism, based off if they are treated with vancomycin or untreated. And 42 patients were in the vancomycin group and 73 patients were the untreated group. And just taking your attention to these statistically significant areas, the gram-positive and Staph aureus were the most prevalent in the untreated group, which just makes sense because vancomycin correctly targets gram-positive organisms. So you get, when you add vancomycin, you have a statistically significant reduction in number of surgical site infections with these organisms as compared to untreated. Then where it gets interesting is if you look at the gram-negative organisms, the exact opposite happens. It seems that patients that have vancomycin have a higher percentage chance of having a gram-negative infection, as well as also polymicrobial infections. So then they went to look a little further, and they were interested in seeing that the patients that do get infected after they're getting treated with vancomycin, are these more extensive infections? Do they need more additional surgery, like additional repeat incision and drainages? They need more antibiotics, assuming if it's more polymicrobial, if they need to be put on several IV antibiotics to treat their infection, or if their length of stay was different. None of this was statistically significant, suggesting that the infection severity is similar in the vancomycin group versus the untreated group. And this last table may be a little challenging to see, but then they took this analysis one step further, and they were interested in by group of infection, whether it be gram-positive, gram-negative, fungal, or polymicrobial, if there's any difference in number of times needed for an IND in this table here. This table here by culture, patients that required more than one antibiotic to treat their infection. And lastly was length of stay. None of the analysis showed any statistical difference seen between the groups. So this goes to show that really that, even though the there's a difference in the type of microbe between vancomycin and the non-treated group, there really is not that much difference in how they're treated or the severity of the infection. So just to conclude, wrap this up, there's a similar rate of infection as seen in previous studies. One thing that they weren't clear about was if the vancomycin actually reduced their infection rate in their cohort. They just gave a total rate of infection and didn't really go into the weeds of break it down. I assume it did, but they weren't very clear on that. And there was a decrease in MSA infection and gram-positive infections after the vancomycin use overall, but it wasn't clear what the rate was. And then there's a higher non-growth rate in patients treated with vancomycin at their index surgery. It's unclear what this is. What they propose, it could be a cultural bias at their institution, that they have a low threshold for taking the patients to the OR. Essentially, any patient that comes with a draining wound, they would take it back to the operating room for IND. And so what they're saying is maybe these patients weren't actually infected and they just did a wound revision. And then there's no significant difference between number of antibiotics needed to treat, length of stay, or repeated IND between the two groups. Some conclusions that they made is there is an association between the use of vancomycin powder and a relative increase in prevalence of gram-negative and polymicrobial infections, but there is no difference in type of care required for these and between these two groups. So even though there is a difference, it may not clinically matter. And then they kind of propose that potentially adding another intraoperative agent to cover gram-negative organisms may help reduce the total rate of SSI in spinal surgery. So there's a couple of critiques I had of this paper. It was a single center study, and they didn't really break down the types of cases that they did. I'd be really interested to see if doing a non-instrumented versus instrumented, if there's a difference between the microbes between the two groups, and also the extent of surgery, a one-level fusion versus a T3 to the pelvis, to see if there's any differences there as well. And then they had, towards the end of the paper, they contained a lot of non-significant results. I think that the meat of this paper was showing that there was a difference in type of infections in the microbes seen between the treated and untreated groups. And it'd been nice if they would have explored that a little closer. That's all I had. Is there any questions?
Well, thank you, Rick. Great summary. I think you brought up some of the questions that I had. There's no real direct comment onto whether vancomycin does really reduce surgical site infection rates, which is kind of why we're doing it in the first place. I would say that the data here probably does show that it reduces rates if you're looking at majority of non-instrumented fusions versus a majority of instrumented fusions. When you compare vancomycin versus non-vancomycin and a similar rate of infection, we would expect it to be higher in the instrumented group. So again, it's not really looking at that specifically in order to definitively say so. You would need to look at it more closely. But I appreciate you bringing up that point, and kind of as we would expect, really changing the flora of what we're seeing in wounds. And as this becomes more common, we may need to adjust our care accordingly.
Amir, your paper from your work at UCSF was quoted extensively, and that you had some kind of unusual findings or comments on this no-growth phenomenon also. Sure. Can you elaborate on that?
And, we saw, we had, and these were, we talked about the culture of, taking something back if it's continuing to drain. I didn't see, and this was a retrospective review, that, there was a kind of quick to pull the trigger type of effect, but that sometimes you're just not able to grow the actual the bacterium that you're looking for. Part of that might be that because, for instance, staph epi can take quite a long time now. If you, for instance, in shoulder infections, you're holding these for up to a month just to get it to grow. That was not the standard back then. So there are some things. One, it may not be growing, and two, you may not be holding it long enough to get the kind of offensive actor to grow.
Well, also, it's unclear. Sometimes a patient comes in the emergency department and they get started on antibiotics immediately. Or if it's a draining wound, you may, write them a script for Keflex or something to see if you can get them through it. So, I think that these sterile cultures probably were positive at one point. It's just not growing out anything.